So Ngākri Nungi, Nanawa Michi Paul Worley, Ngāpi Puteri Māori Pomerank, Nanajeri Rui. G'day, and my name is Paul Worley, the Executive Director for Clinical Innovation in the Riverland Academy of Clinical Excellence. I'm here on Nanajeri country today at Murray Bridge, and it's great to welcome you all to our grand round, an opportunity for us to hear from experts from around the world about cutting edge research and technology in healthcare and how we may be able to learn from that and collaborate in its development and application for patients in our region. Today we're very fortunate to be looking at the area of senior Australians or aged care. Many of you will remember that we had Professor Julie Radcliffe talk to us, present a grand round last year, looking at issues of quality in the care of senior Australians and the work that had been done at Flinders. We're very fortunate also in South Australia to have this registry of senior Australians, which is such a wonderful resource to develop policy, to develop practice, and to look at the implications and the outcomes and the impact of that policy and practice. And there's no one better to explain the potential and some of the activities of that group than Stephanie Harrison from both SAMRI and Flinders University. Stephanie, it's great to have you here, and we look forward to hearing from you and then the opportunity to ask you some questions at the end of our short time together. So over to you.
Perfect. Thank you, Paul. Thank you very much for inviting me to speak with you all today. As Paul mentioned, I'm from the Registry of Senior Australians, or ROSA, and today I'll be talking about how we use ROSA to monitor and hopefully improve aged care quality. I'll be talking about some of our recent projects and also our plans for future directions as well. So I'd just like to start by acknowledging the Kaurna people of the traditional custodians of the Adelaide region where I'm based today, and recognise their cultural, spiritual, physical and emotional connection with the land, and honour and pay my respects to Kaurna elders, both past and present, and all generations of Kaurna people now and into the future. I'd also like to acknowledge other traditional owners across South Australia where other people may be joining from today, or wider Australia. Thank you. And today, as Paul mentioned, I'll be talking about aged care. So just to give a very brief overview of the current landscape of aged care in Australia and some of the different services I'll be referring to. So there's around 1.5 million people accessing aged care, and the services they access range from basic support at home services through the Commonwealth Home Support Programme, through to more comprehensive home care through home care packages, and then residential care through respite or permanent residential care, and then fewer people accessing short-term restorative care as well. So you see on the first pie chart that over half of people accessing aged care are accessing those basic support at home services, things like basic services for gardening, domestic care. But when we look at how much spending we spend on different services, the majority is spent on residential care at over $16 billion annually. The 2023-2024 budget for aged care was $36 billion, or over a quarter of government's commitment across health, aged care and also sport. And with the aging population and the projected demand for different services, it's important that we ensure quality of aged care and that different services are provided to meet the demands of older Australians. So the Registry of Senior Australians, or ROSA, was established in 2017 as an Australian clinical quality registry and data platform. It's a partnership between researchers, clinicians, care providers and also consumer advocates. So when we're conducting research and trying to improve quality of care and quality of ageing for older Australians and older people worldwide, we have to consider that a lot of research studies, clinical trials often exclude these individuals. They're often excluded because they have high prevalence of comorbidities, polypharmacy. People are often living with cognitive impairment or dementia. And so they don't meet the criteria for inclusion in clinical trials, or they're not able to participate. And that's why the use of real-world or routinely collected data is very valuable in this population to conduct research studies at a scale that would not otherwise be feasible, and to be representative of the diverse and heterogeneous population accessing aged care. So there's lots of data about people's health and aged care service use across Australia, and also social welfare. And we've linked that together within ROSA to provide a full picture of the ageing pathway once people start to access aged care in Australia, and with the aim of improving quality of ageing and aged care. There are currently 32 team members within ROSA. We're based at SAMRI, at the South Australian Health and Medical Research Institute, and our key academic partnership is with Flinders. As you can imagine, we have a lot of data, a lot of numbers. So we have a mix of epidemiologists, statisticians, data analysts, computer scientists. We do a lot of work about medicine use, so pharmacoepidemiologists, and we have input from clinicians and also health economists as well. And this quite busy figure gives an overview of what ROSA looks like. So we have two main core data sources within ROSA. We have the prospective ROSA, which is South Australia only, and people consent to be part of that at the time of their aged care eligibility assessment through an opt-out process that started in 2018 and includes over 53,000 individuals up to 2022. And then we also have our historical ROSA, which is a national resource. It's completely de-identified. It spans almost 20 years and includes nearly 4 million individuals. And we can see on the second column the data sources that are linked within ROSA. So we start with the aged care data that we have available to determine when people access aged care, what approvals they receive, what services they go on to access or not. And then we link that with people's other health information. So hospitalizations for 4 states, South Australia, New South Wales, Victoria and Queensland, medicine use through the PBS, also MBS services, and lots of other health care data, and some of which have been quite newly linked, and I'll be talking a bit more when I talk about the future directions of ROSA. So you can imagine with all this data, we can answer a lot of varied questions about people's aged care services and also their outcomes after trying to access services. So ultimately, registries are designed to examine unwarranted variation, and unwarranted variation is variation in care or outcomes experienced by people that cannot be explained by differences in their health or care needs. And it's usually an indication that there's disagreements regarding how best to treat people. It may be indication that inappropriate care is being delivered. And it's usually an indication that we can improve services to optimize consistency of quality across the board. So in relation to unwarranted variation, the ROSA outcome monitoring system was developed as a tool for quality and safety monitoring and benchmarking. So we're using that existing information I've talked about within ROSA to provide aged care providers with an overview about different aspects of their care and outcomes of their residents or the people they provide care for. And we can examine that unwarranted variation for different aspects of care quality. I'll provide some examples of that. So this is our an example of an outcome monitoring system report we provide to residential care facilities. We also have an outcome monitoring system for home care providers as well. So this is using that prospective ROSA, which is just South Australia. So we provide different care providers with reports about different aspects of quality shown here. So we could provide information about medicines their residents are using, information about hospitalizations and mortality related quality indicators as well. On the right, to give an example of how people can see the variation in different quality indicators. This shows chronic opioid use. So this is a funnel plot which shows the proportion of people within a facility that are experiencing chronic opioid use. Each dot is a different facility, and we label the provider's service in a different colour so they can easily identify where their service sits in relation to other services, and say if they were out of the expected range, and then they might look into that further and identify if there's anything they can do to improve quality for that particular quality indicator. So also what ROSA has done, when the outcome monitoring system was being developed, also the Royal Commission into Aged Care Quality and Safety was ongoing between 2019 and 2021. So ROSA provided 8 commission reports for the Royal Commission, and 6 of those were based around the ROSA outcome monitoring system. We also had other reports looking at specific aspects of care and experiences for individuals in aged care, such as psychotropic medicine use. And we had some of the ROSA team were expert witnesses at the Royal Commission, and the government was able to use the information that ROSA provided to help inform their recommendations and also some of the ongoing aged care reforms. So an example of that is the National Aged Care Quality Indicator Programme that was expanded significantly after the Royal Commission and is mandatory for residential aged care facilities. And you'll see quite a lot of the quality indicators that we use as part of the quality indicator programme align with those developed as part of the outcome monitoring system within ROSA. And once these sorts of programs are implemented, we recognise the importance of continued monitoring and refinement of the program. So we're continually working with the Department of Health and Aged Care as they continue to adapt these quality indicator program. So an example of that is we've recently completed a commissioned project from the Department of Health and Aged Care to expand the quality indicator program to include quality indicators for more workforce, so enrolled nurses, allied health professionals and lifestyle officers. So to do this, we completed an evidence review and we conducted a pilot study of 9 quality indicators around these professions with 69 providers nationally. And from that, we recommended 5 quality indicators, which on Monday was announced by the Minister that they will be implemented nationally from next April. And 4 of those use information that's already being collected as part of care, as we are all about utilising routinely collected data and minimising burden for providers as well. As part of the quality indicator programme, the department are also planning to expand this into in-home aged care, and we're also working to help them with that. So again, we've conducted an evidence review as we want to make sure that any programmes or measures that are implemented in aged care are centred around the best evidence base available. So we've shortlisted 3 quality domains: consumer experience, quality of life and service delivery or care planning, and 7 different quality indicators, which we are about to pilot in over 200 in-home services nationally later this month. So in addition to the quality indicator programme, another way that another programme that has been introduced since the Royal Commission to help people monitor quality in aged care is the star rating system in residential care. So this was introduced following the Royal Commission in December 2022. It is a 1 to 5 star rating that each facility receives based on 4 subcategories: residents' experience, compliance, staffing and quality measures. And the percentages correspond to different weights that each subcategory is given to make up the overall star rating for each facility. And with the introduction of this, we understand the importance for continued monitoring and refinement of programs. So we've done some work using publicly available data of star ratings in residential care very recently. So we did a study of 2,476 facilities to examine associations between facility characteristics and odds of receiving a high 4 or 5-star rating. And we also examined changes in ratings over time. So we found that over half of facilities do receive a 4 or 5-star rating. And when we examine facility characteristics, being a smaller size, having government ownership, or being located in a socioeconomically advantaged area were all associated with 4 or 5-star ratings. So that is similar to what we see nationally and internationally when we've examined facility characteristics that associate with better quality care. Is usually the smaller facilities and government operated that associate with better quality of care, and is important firstly because there is a trend for more larger facilities, and we want to make sure that evidence informs that people are given choice in the type of residential aged care facility, and that we show what characteristics associate with better quality care. And it's also an indication that the 4 or 5-star ratings may be actually representing better quality care, as these are the associations we would have expected. When we looked at changes over time, so the media and government have reported that star ratings are increasing over time, but when we looked at the data in a bit more detail, we see that yes, over time, average star ratings are increasing, but some facilities are also declining. And when we look at the different subcategories, there are quite a lot of fluctuations, increases and decreases, especially for quality measures. And it's important to monitor these, because if they're not consistently being rated the same quality, again, it might be an indication of some variation and need for improvement. So we have done a lot of work in the past in ROSA.
Stephanie, your mute has just gone on when you introduced this slide.
Oh, sorry, I'll start this slide again. Thank you, Paul.
Great.
Sorry about that. So, yeah, we've done a lot of work about residential care, but we know that it's also important to examine home care services, as we know over time that there is an increased demand for home care. The preference for the vast majority of older people is to age in place, i.e. to stay in their own homes for as long as possible and delay entry into residential aged care. And the government have introduced a lot more home care packages recently. So we will see an increase in the use of home care, and we have projected a decline over time in the use of permanent residential aged care. So although we have already started examining quality and safety within home care through the ROSA outcome monitoring system, future plans are to examine further quality and safety in home care. So for instance, we've recently examined the rate of hospitalizations in people accessing home care compared to permanent residential aged care. And we see higher utilisation of emergency department presentations, unplanned hospitalizations, and also potentially preventable hospitalizations in people using home care compared to permanent residential aged care. And overall, in 2019, people accessing home care spent double the amount of days in hospital compared to people accessing permanent residential aged care. So not only do we want to ensure high quality of home care services so that people can delay entry to residential aged care and stay at home for longer, we want to ensure that when people are staying at home, that they're not spending a lot of time in hospital. So as part of the future plans, we have large projects planned to evaluate safety and quality in long-term home care. So this is timely with the government's planned overhaul of home care in terms of the new support at home programme, which is being planned to bring together the Commonwealth Home Support Programme and home care packages, and to reform how those services are offered. So we think that by doing that, we can inform the future reforms around home care. So I mentioned earlier all the data sets within ROSA. So a few of those are quite newly linked within ROSA. So we have the Domino data set, which is from Centrelink and provides a lot of information about social welfare payments people receive and other social determinants, which we will be using to build a better picture of someone's socioeconomic status. And we plan to examine how that impacts access to home care. As we know, there's quite a complex financial pathway people have to navigate, for instance. We have the Australasian Rehabilitation Outcomes Centre data linked. So we'll be looking at rehabilitation used in this population. And we'll soon have workforce information from Stuart Brown linked. It should be very exciting because we know that workforce is a very important component of care, and we'll be able to look at this in a way that's not been examined before. So I've talked a lot today about overview of looking at aged care for the general population accessing services, but within that population we can look at specific health conditions or events for individuals. So an example of that is we have a Stroke Foundation funded project to look at access to long-term services for people following stroke. And also we have our Consumer and Community Advisory Committee, who inform a lot of our projects and who are co-investigators on a lot of our projects. And we have some specific consumer-driven projects, such as we have a Health Translation SA funded project to look at the experience of informal carers. So I'll just finish off with a few slides about some key achievements within ROSA. So since 2017, when it was established, as well as the outcome monitoring system development, which informed the Royal Commission on Aged Care Reforms. We do a lot of academic publications. We do a lot of work with the government. We provide the outcome monitoring system reports directly to care providers. We try to do community engagement activities and media events, and we've received nearly $36 million in competitive funding over time. And I just wanted to acknowledge our governance structure. So we have as well as that core ROSA team, we have our ROSA steering committee. I mentioned our Consumer and Community Advisory Committee. We have our Aboriginal and Torres Strait Islander committee. And we have a specific committee for the outcome monitoring system. So this is our ROSA Research Centre team. So if anyone is interested in specific topic areas of aged care, we are likely to have someone who is interested in that too. I'd just like to acknowledge our partners. So we have partners who are aged care providers, funders, data custodians, who all without we won't be able to bring this resource together. Thank you, and I'm happy to take any questions today, or also email or reach out to our ROSA project team. Thank you very much.
Thank you very much, Stephanie. That's fascinating work, and it just reminds me how so much good work is done in South Australia, and yet we don't necessarily know about it. So it's wonderful to have that. While people are thinking of some questions, and please put your hand up if you have a question. I'll ask a couple. So you mentioned that the star rating is dependent on, or is influenced very much by three variables. Small. In Riverland, Mallee, Coorong, we have multiple small aged care facilities, government run. We are government run. But the third one was high socioeconomic area. Now, we can't do anything about that. In fact, we have none of our SA2s are in the top 3 quintiles. So not the top quintile, not the top 2 quintiles, none of them are in the top 3 quintiles for SES. So aren't we sort of competing in the star system with one big hand tied behind our back if that has such an influence on the star ratings?
Thanks, Paul. So firstly, I'll just mention that if you've got smaller size of government ownership, they were the odds are a lot higher for those. So it's more positive than the socioeconomic factors. But I think it's just important to show this because, again, there's nothing that you can do to change your location. But if we do further analysis to look at the individual subcategories, for instance, so like staffing, it may be, an indicator of further resources that need to be directed to those areas. So we think it is a good thing in terms of highlighting to policymakers where they need to direct resources. So hopefully with our workforce data being linked, we'll be doing a lot more work around potentially highlighting workforce shortages, etc., in different areas.
Yeah, thanks for that. Of course, one area of workforce and policy intersection that affects us a lot because of being a provider of last resort is the interaction between aged care and the NDIS. Where there's often a lot of confusion for consumers around that. Are you looking to link those data sets as well in the same way as you have linked some of the other data sets?
We haven't today, just because our ethics and everything is all set up for people over 65, and I know the NDIS is meant to be for people under 65, but I know it's not always the case. For instance, we've done projects about showing the young people accessing aged care, etc. But no, that's an interesting point. We haven't, but maybe it is something that we should explore in the future, and the kind of transitions maybe between accessing NDIS and then aged care. Yeah.
Certainly,
I'm just interested. So I'm not as familiar with NDIS services. So say for instance in ROSA, our kind of key entry point is when people have an aged care eligibility assessment. They have an ACAT. With NDIS, is there a similar process? I'm asking you questions now.
Yes, there is. Yeah, there absolutely is. So there would be a way of potentially linking those, and it certainly is an issue that you're for rural areas. Another thing that came from your data was it was interesting to note that the rate of residential aged care per 1,000 people is predicted to decline. However, so that's the numerator, if you like, is predicted to decline, but the denominator is predicted, especially in rural areas, to increase dramatically. The number of people over 65. So what are your projections around the need for residential aged care beds when you factor in the decreasing numerator but the increasing denominator? Where does that land us in terms of our planning, for instance?
Yeah, that's a good question. I don't have those numbers off the top of my head, but I can share that full paper with you and other projections people have done. But I think overall, as you say, yes, the population is aging, so we will see more people accessing all types of aged care services. But I will go back and check. But I think there is a point where it comes to that we will start to see a stabilisation in the kind of number of beds we will need, because of the shift to people accessing home care. But obviously there's a lot of factors. It'll depend if the government keeps offering more home care packages. That will help, hopefully as well, so people stay at home longer. but yes, you're right. What we've shown here is the rate, but because there'll be more people, we will see still some increased demand. But I think that there is a point where it kind of will stable, and then with people accessing more at-home services.
No, so look, thank you for that, and thank you for the offer of sharing the paper. Just again, we're promoting curiosity and curiosity-driven research and evaluation and question asking. If people have questions that they think ROSA might be able to help them answer, how do they go about linking with you from our local health network?
So I think firstly, just start by contacting either our generic ROSA email or myself, or any of the ROSA team I've mentioned today. Everyone is very helpful, and reach out and talk to us, because often people talk to us and it's projects we're either planning or ongoing or have already done. So we can point you to what we have already done, and then we can or what we're planning, and then we can talk about what we have available in ROSA. And we're very keen to collaborate with people. So obviously there's lots of research questions within this population we want to answer, and our limited resources. So what we normally do is we develop a collaboration. If it's not a project we already have ongoing or planned in the future, then we start to look at available funding resources and developing grant applications together, as we are primarily grant driven. But we're always welcome new ideas from different sectors, and we try to welcome new collaborations. But yeah, I think just reach out, and then we can go from there.
Michelle, you've got a comment or a question.
Yeah, just a question. I was interested when you said that there's some reports that would be available from ROSA. I know obviously we take part in the National Quality Indicator Programme and obviously the star ratings, but I was just interested if we can get in touch with you and we could sort of just ask whatever reports that we would like as a side to what we already have information on.
Yes, definitely. So if you're a provider within South Australia, then we can provide reports. So you either you can contact me afterwards and I'll pass it on to our project officer, or contact the generic ROSA email address, and just give a bit of details. And definitely that is something we can help with.
Thank you. Thanks very much.
Yeah. And please, share that information with anyone else, any other providers, and that as we make these reports, we have all this information ready to go, and we try to do meetings with different health networks to reach out to people. But yeah, it's there, it's available. So please do get in touch.
So Ananti, Stephanie, thank you. And thank you everyone for being part of this grand round. That interaction that you showed between home care, residential aged care, and acute hospital usage, of course, is very relevant to us because we're in each of those three spaces and trying to make that work as best we can for our community. So I think the work that you're doing is really important for us. And we look forward to being able to ask better questions and work with you about how we can source funding together to answer some of those questions together. Thank you, everybody, for your participation today. As the Nurrungeri say, Nakan, we will see you later. And particularly for this grand round, we'll see you in a month's time. But thank you very much, Stephanie, and for the work that ROSA is doing.
Thank you very much for the invitation. It's very nice to meet everyone. If you're interested, like I say, in ROSA, please reach out with any of your questions and ideas or queries. Thank you.